Hey everybody, this is the highest yield. The next 8 minutes are going to be split into 3 sections. 1, clinical pearls, essentially clinical acumen that you should apply to every orthopedic consultation. 2, diagnosis and description of fractures. And 3, acute care and dispo, which is what you do there and then in the ED and how to make sure every patient has appropriate follow-up. Working through this brief list, the 2 most important points are that the history is crucial in directing your exam and imaging, and that you should evaluate the neurovascular status distal to suspected injury site as quick as possible to rule out a life or limb situation. Other general principles are to be suspicious of pathological fractures in the absence of trauma, and then to look for other pathological fractures. Rib fractures in children or fractures of any kind in non-weight-bearing children are suspicious for non-accidental trauma, and you have a duty to report should your level of suspicion be reasonable. Assess for swelling, erythema, atrophy, and deformities. Examine proximal and distal to the site of injury, and to perform both active and passive range of motion, as sometimes the pain and swelling can inhibit active range of motion, but you can still assess the mobility of the joint yourself. 2 more crucial points. Assess for multiple views on imaging, and imaging is not a replacement for a thorough history and physical. Note the imaging on the left here. This mid-shaft fracture of the humerus is invisible on one of the left views. Use the acronym SOLO-D-SARC to remember the ways to describe a fracture as accurately as possible during handover or consultation. Is this a Salter-Harris, to be talked about in the next slide? Is this an open or closed fracture? The location, which can be described as the midshaft, juncture between the proximal and middle third, juncture between the middle and distal third, the neck or the head, the orientation of the fracture, as in how does the crack lie, displacement, which is how the pieces sit relative to each other, not considering angulation, depicted on the small picture to the right here, shortening, are the pieces overlapping, angulation, which is exactly how it sounds, rotational, which can be hard to evaluate, and concomitant subluxation, which is partial dislocation or dislocation itself. Salter-Harris fractures by definition involve the epiphyseal plate and therefore can only happen in children and adolescents. The acronym is straight, above, low, through, and rammed. Note that the E is absent and ensure that there is orthopedic follow-up. Now that we've characterized the type of fractures that we can see on film, there are cardinal rules to apply to every fracture. 1, NPO, in case of procedural anesthesia for reduction. 2, remove the jewelry. 3, analgesia. 4, recognize and reduce, and the things you want to recognize include compartment syndrome, which presents as pain at a proportion, neurovascular compromise, which presents as no pulse, impaired sensation, or impaired motor function, open fractures, which always need orthopedic consult and possibly the OR, and finally, back to the list, 5, immobilization and disposition/follow-up. Now to lend some substance to this acute care section, we are going to touch upon some high-yield ortho injuries that you'll see time and time again. First, the classic Fouche mechanism, fall on outstretched hand, resulting in the classic Coleys fracture. The Coleys fracture is basically a fracture of the distal radius with dorsal angulation, displacement, and may be shortened as well. Treatment may include sedation and anesthesia, reduction, and splinting using a dorsal/volar slab and ortho follow-up. If the scaphoid is tender, and the scaphoid is generally located at the snuff box at the base of the thumb, then you should consider adding scaphoid views on top of the usual hand x-ray series. Note that this bone, the scaphoid, has poor circulation and is prone to AVN, avascular necrosis. Additionally, for a suspected scaphoid injury, add on a thumb spica and a hand/ortho consultation. Finally, note that in the interest of time, splinting technique will not be covered in this video. This is something which is best taught in person. Next up is the classic angry dude boxer's fracture. Aptly named, the boxer fracture is often a result of punching a hard surface. It is a fracture in the neck of the 4th or 5th metacarpal, much less commonly the 3rd metacarpal. Treatment may include sedation and anesthesia, reduction, and splinting using an ulnar gutter, and requires orthoclinic follow-up. We will touch upon fight bites on the next slide. Look to see if there's a bite wound on the puncher's hand, a fight bite. Fun facts: if untreated, cat bites have an 80% chance of getting infected. Human bites, 10%. Dog bites, 5%. But in any of these cases, cover with amoxicillin/clavulinate 875 milligrams POBID for 5 to 7 days. Finally, we have the ATFL sprain. You sprain your anterior talofibular ligament plus or minus the calcaneofibular ligament via an ankle inversion injury. Usually, the film is pretty unimpressive. Therefore, you'll want to assess two things at this point: stability and ability to weight bear. We'll talk about the ankle mortise and the drawer test and the Taylor tilt test in the subsequent slide. Moving forward for now, if the patient has a stable joint and is able to weight bear, consider ankle brace and follow up with their family doctor in 1 week. If the ankle is stable but is unable to weight bear, consider ankle brace and crutches and consider orthopedics consult. If the ankle is unstable and therefore is unable to weight bear, they need a posterior splint to immobilize the ankle and follow up with ortho. Note that the patient might not even need imaging, and we'll talk about the Ottawa ankle rules in a slide soon. Look at this ankle mortise on the left. The ankle mortise view is a view of the distal tibia, distal fibula, talus, and proximal metatarsals. The lines of the talar dome on the bottom there should run parallel to the lines of the distal tibia and fibula on the top there. The middle image shows a collapsed ankle mortise. This indicates an unstable joint. Additionally, to the right, if the anterior drawer test or the Taylor tilt test endorse excessive laxity, this adds to the picture of an unstable joint. Ankle brace for stable ankle joints on the left, posterior leg splint for unstable ankle joints on the right. The Ottawa ankle rules. We said that films of the ankle when the mechanism is ankle inversion are usually negative, so why image if you don't have to? These rules help us make that decision. Inability to weight bear immediately and in the emergency department? Image. Pain around the posterior aspect of the malleoli? Image. Pain at the proximal base of the fifth metatarsal or navicular? Image. None of the above, the patient unlikely has any clinically significant fractures and does not require imaging. Thanks everybody. We didn't get to cover physical exams or essentials of casting, but this will hopefully be covered in a later episode. Stay tuned. This is The Highest Yield.